to give you a little bit of background, presumably most people know about the Medicare system, but you may or may not know that Medicare took approximately 40 years to figure out that it might want to offer insurance for prescription drugs. It was about 30 years behind the private sector. It's not so bad when it comes down to a government program, though. So in 2006, they started to cover prescription drugs as part of their standard benefit through this mechanism of the Medicare Modernization Act. And one of the important features of the Medicare Modernization Act was that unlike the rest of the Medicare system, or at least parts of the Medicare system, where the government pays insurance claims directly, instead, the Medicare prescription drug benefit was done through the private sector. Okay, so essentially, the legislation provided a subsidy for Medicare beneficiaries to go out and purchase prescription drug insurance on the private market. And that's an important feature here. So Medicare pays about 3/4 of the premium for Medicare beneficiaries. Anybody can, in principle, offer a benefit to Medicare beneficiaries. If they meet various qualifying characteristics, they have to cover certain kinds of drugs, and they have to offer kind of a minimum benefit level. So the initial projections for Part D's costs were about $1 trillion of claims over 10 years. It's actually a little bit lower than that for reasons that maybe we'll see later on. But it's a fairly significant program. It's growing in importance because prescription drugs are rising as a share of healthcare expenditure. Now, there are a few things that are already known about Part D, which is the name of the prescription drug benefit. One is that it lowered the prices of drugs that were more heavily exposed to the Part D program. And the hypothesis here is if you've ever had the misfortune of going to a pharmacy and buying a prescription drug or buying a prescription without insurance, you might know that the pharmacy will charge you vastly more when you're uninsured than when you go in there under the umbrella of Blue Cross or Blue Shield or whoever your insurance provider. I won't go into the specifics of how one pins the stock price increase on the Part D effect, but there are several papers that I think are reasonably plausible and credible. So it does suggest that there's an increase in the profitability of drug companies after the law was passed. And the final known effect of Part D is that, of course, now that you have all these subsidies for the purchase of prescription drug insurance, a whole pile of new customers were just essentially airdropped onto the insurance industry. So you had big increases in the enrollment and size of private insurers. I should note here that there was no new entrants by additional firms into the insurance marketplace. So essentially you're just dropping more consumers onto the same number of firms, so these firms got bigger. And what is of interest to us in this paper is what effects did it have when the prescription drug insurers got bigger as a result of the Part D legislation. So in particular, you might hypothesize, at least we hypothesize, that bigger insurance companies could arguably get better deals on drugs. Okay, so a bigger company can throw its weight around and say, if you don't give me a good deal, I'm taking my business elsewhere, and they might strike more fear into the hearts of the companies they're negotiating against. So the question is, first of all, did that happen? Did increases in the size of insurers lead to them getting better deals on the drugs that they were purchasing for their insureds? And also, if it did those price declines spill over into the non-Medicare portions of the market? So if you think about it, if I am covered by Aetna, and Aetna just received a 500,000 or 750,000 additional prescription drug enrollees as a result of Part D, Aetna might become bigger and badder and get better deals on its drugs, and it might get better deals on its drugs for everybody, even the insureds who are outside the Part D program. Okay, so those are kind of the questions we want to know. Did it lower drug prices for people inside the program? Did it lower drug prices for people outside the program? And if so, where were those price declines most noticeable? And in particular, were they exacted from weak generic drug manufacturers or strong branded drug manufacturers? Okay, if you're making a patented branded drug, you have a lot more leverage and power when you negotiate prices because your drug is more unique. Okay, so you have the person across the table from you has a harder time walking away because they don't have a ready substitute for whatever it is that you're producing. Okay, so I'm going to breeze through parts of this given the time, but I'll give you a very brief introduction to the economic analysis of the problem. Then I'll talk a little bit about how we identify the empirical effects and some of the policy implications. So the first thing, very briefly, I'll talk to you about is the Byzantine nature of drug pricing in the United States. Okay, so the first thing that happens, actually it's even more complicated than this slide suggests, but I'm going to simplify it a little bit. So let's think about a prescription drug manufacturer like Pfizer, or Novartis, or Sanofi Aventis. They discover drugs and they sell drugs. The first thing that happens is they sell drugs to a wholesaler. Okay? McKesson is a very big wholesaler, for example. And the wholesaler then transports drugs and it pays the manufacturer for the drug. Okay? Usually it's a very simple contract involving a linear price for the drug, maybe a small volume discount. And then the wholesaler goes off and distributes the drug to pharmacies like CVS, Walgreens, etc. Then the pharmacy pays the wholesaler for the drug. Okay, they negotiate some price. And then the pharmacy dispenses the drug to patients. Okay, and some of these patients are enrolled in insurance plans, so we think of them as enrollees. And the enrollees might pay some co-payment to the pharmacy. So when you go down to the pharmacy, you show your Aetna prescription drug card, they say, okay, you just purchased a branded drug, that'll be $15 out of pocket for you. So you pay the pharmacy that out-of-pocket cost. And then your insurance company pays some balance to the pharmacy. So maybe the prescription costs $150, and the pharmacy asks you to pay $20 and collects $130 from your insurance company. That's the negotiated reimbursement from the insurance company. And then, of course, if you're insured by Aetna, you're probably paying Aetna a premium, or your employer is paying Aetna a premium. And that makes up this difference between your out-of-pocket cost and whatever the insurance company is paying for your drug. Now, there are a couple of tricky little features of the pricing situation that are largely designed to circumvent government regulation. Okay, and in particular, there are a number of negotiated rebates that will be paid from drug manufacturers directly to insurance companies. So Pfizer might go to Aetna and say, if you sell X million prescriptions of this particular drug, I will give you a kickback, essentially, of 3% of the total cost of the drug. Okay, that's known as a rebate that's negotiated between the manufacturer and the insurer. Notably, there are no rebates between insurers and pharmacies, only rebates between drug companies and insurance companies. And now the rebates are all confidential. Okay, I've seen rebates once or twice, and I signed away my children's livelihoods in order to never use them in research. So nobody has ever used rebates in research because they're highly confidential pieces of information. So that essentially means is that no researcher ever has the actual price of a drug. Okay, and that is to say, you don't know the true price net of the rebate that is being paid by a manufacturer to the insurance company. But we do have completely accurate information on what an insurance company is paying a pharmacy for the drug. Okay, so you know accurate prices on one side of the market, but not on the other side of the market. And we will be exploiting that fact in this paper. So essentially there are three sets of players here. There are insurers, there are drug companies, and then there are pharmacies. Okay, and all of these guys, this is obviously these are huge sophisticated companies, and they're negotiating on a case-by-case basis prices for these drugs. So insurers and pharmacies bargain over how much the insurer is going to reimburse a pharmacy for a particular drug. Drug companies and insurers are also bargaining, and drug companies and pharmacies are even bargaining as well. So there's this three-way bargaining going on. I'm not going to go through the details of the bargaining problem, but I'm going to show you a few kind of simple conclusions from it. One is that in a bargaining problem like this, if the insurance company becomes bigger and badder and gets a better deal for itself from, say, a pharmacy, it's also theoretically going to be the case that it must be getting a better deal for itself from the manufacturer. Okay, so in that sense, if we can observe how well the insurance company is doing negotiating against a pharmacy, we know at least qualitatively whether it's doing better or worse negotiating against a drug company. The second result is, I think, quite important, and that is that think about this three-way scheme where you have a manufacturer that's selling a drug upstream, and then you have these two other parties, the pharmacy and the insurer, fighting over scraps, essentially. Okay, so they are, little Pekingese around the dinner table yipping for scraps. And the question really is, how many scraps end up on the floor for them to fight over? Now, if they're dealing with a branded drug where there's a patent involved and it's a very unique drug, that manufacturer has a ton of leverage. Okay, suppose it's a drug to treat leukemia and there's no other alternative drug. So this, there's an example of a drug called Gleevec, for example. It was the only treatment for chronic myeloid leukemia about 15 years ago. If you're the manufacturer of Gleevec, you have a ton of leverage when you go to the table against an insurance company or a pharmacy, because you say to them, okay, either you play ball with me or everybody in your network with leukemia dies, rather than lives an additional 15 years. That's a pretty big stick, right? And so a company like that is going to get a really good deal selling its drugs. And so essentially it's going to soak up all of the available profit, and there are going to be very few scraps thrown onto the floor for pharmacies and insurers to fight over. On the other hand, you can think about a generic drug company that's selling a molecule that 5 other companies are selling the identical molecule. It has virtually no leverage. So it's going to throw a big stake onto the floor because it can't compete when negotiating against the pharmacy and the insurance company. So all of that analysis implies that we ought to see a much bigger effect on the negotiation between insurance companies and pharmacies when we're looking at generic drugs. Because only for generic drugs is there a lot of money flowing downstream to these two players. For branded drugs, there's basically no money to be made for anybody other than the company that's producing the patented drug. Okay, and we will see that in spades, actually, in a couple of, yeah.
Now, what about strategic behavior around those generics, though, that are tied to your very exclusive drugs? So one of the strategies that you might have, for example, is to offer a portfolio instead of pricing. So if you want my exclusive drug that cures leukemia, you also have to, right? This also gives me power to extract more in bargaining behavior out of my generics.
Right. In principle, that's possible. It would probably be frowned upon by the FCC, or the FTC, I should say. If you look at the way drug companies structure their generic portfolios, two things are evident. One is that there are just straight generic companies. There are, so that's it's simple. There's no tying. There are companies that have generic and branded portfolios. Usually inside the corporate structure of the company, there's a firewall between the generics division and the branded division. Now, you could argue that that firewall is a sham, and that in fact there's tying across the generic and the branded drug. It's possible, but the problem is that it's really costly to get high prices on your generic because you're staring across the table at somebody who has really good alternatives. So usually if you have a branded drug that you have a lot of leverage on, you might as well just get a high price for the branded drug rather than using it to leverage your generic, because your profit margins on your generic are not really going to be high even in the best case scenario. So I think it's in principle possible. There's some legal obstacles. In general, I'm not a big fan of believing in legal obstacles. I think companies will get around them if there's a strong incentive. But I don't know that there's such a strong incentive. If I had a really great branded drug, I would just soak the hell out of everybody on my branded drug without trying to use it to drive business towards my generic. But it's a good question. So I'm going to skip over this. Then the last point, it turns out that this is actually a point that is intuitive to economists but to no other person on the planet, and that is that it's actually ambiguous as to whether bigger buyers get better or worse prices. And the real issue here is that you'll get a good deal if you're generating a lot of profit per unit for the person that you're negotiating against. Okay, and so that really, whether or not a bigger buyer is able to do that is a question of how economies of scale operate inside the company. So if it's the case, for example, that a big firm is horribly inefficient, it's actually, in fact, probably going to get a worse deal because it doesn't provide as much value to its trading partner due to the fact that its own cost structure is so high. Okay, so in principle, it's possible for larger buyers to get better deals. It's also possible for larger buyers to get worse deals. That's just an observation so that it's an empirical matter, whether bigger companies get better prices or worse prices. In most previous literature in the pharmaceutical industry, the finding has been that bigger buyers get better deals. And the rationale has been that there are some economies of scale in the production of pharmaceuticals that show up in this. But I'll just make that an observation so that you don't come away with the notion that bigger is always better when you're negotiating. Okay, so given this, so the questions here are, first of all, do bigger buyers get better deals? Do they get lower prices? In particular, do bigger pharmacies get better deals from insurance companies? Do bigger insurance companies get better deals from pharmacies? And in particular, do those deals seem to be different for branded drugs where there's this big bad manufacturer versus generic drugs where there's a very weak manufacturer? Those are the key hypotheses. So what we do is we look at claims data from a very large retail pharmacy that controls about a quarter of the U.S. pharmacy market. It's in 45 states. The data that we have span the introduction of Medicare Part D. So it goes from the third quarter of 2004 to the first quarter of 2007. It has essentially the claim filed by the patient in purchasing the drug. I should note that these data are actually, they're Wes Yin's, my co-author Wes Yin's data. So I have actually never been allowed to look at it, but I'm actually told that it exists. So and I'll show you some results about it. Yeah. It's by total revenues. Yeah. So the data can be used to construct the average price per pill, okay, by insurance company, drug, and quarter. Okay, so we would know, for example, how much Aetna was paying for Plavix in July of 2006, okay, and similarly for other drugs and insurance companies. We also have data on Part D generosity and benefit design. We have enrollment data for all Part D plans, and we have this plan landscape file showing us how generous each plan is. Just very briefly, as you might expect in a data set like this, we overrepresent large insurers and underrepresent small insurers simply because a small insurance company is kind of by definition less likely to be in a probability sample like this. So this is primarily about larger insurance companies, although it's still a fair number of insurers are covered. Now, the other point that is worth making here is that what we really care about is profits per pill, but profits are fundamentally unobserved. What we observe are prices. But here's a little subtraction trick that we use to get at profits. Okay, the idea is if I'm running CVS and I go out and I need to sell prescriptions of Plavix, what do? I go out to a wholesaler and I buy a bunch of units of Plavix. And then I go back, I ship those to my pharmacy and I start selling them to people with insurance coverage. Now the point is that my cost of Plavix is one number. I go out to the wholesaler and I buy the Plavix prescription at one price. But the reimbursement I get from the insurance company is a bunch of different numbers. Okay, I might give a better deal to Aetna and a worse deal to United or whatever. So I'm going to have a bunch of different numbers for insurance companies, but only one cost. So what that means is when I look at the difference in price paid within a drug across a different insurance company, what I'm isolating is actually the change in profits across the insurance company. Okay? Because if Aetna, for example, is paying $1 per pill more than United, I can safely conclude that that's an additional $1 of profit that's going to Walgreens. Okay? Because Walgreens is in fact paying the same amount of money for Plavix no matter who it's selling to. It's going out and getting the best deal on Plavix and then selling it. So that's the way we kind of back into a measurement of profitability. Now here's a really, I think, striking, even shocking picture. That this is an example of economics actually working. Okay, so if you look at the distribution of prices for different drugs across insurance companies, what you'll observe is that there's much more variation in the price for generic drugs, even when you look at the price level. Okay, so what does this mean? So I'm looking at a generic drug which in general costs about 10 times less than a branded drug. But the absolute dollars of profit, even the absolute dollars of profit, forget about the percentage. the absolute dollars of profit being earned by the pharmacy are higher on generic drugs. Okay, which is to say, all the generic drug companies are just getting screwed when they're negotiating because they're these competitors that have identical substitutes. So all this money is flowing downstream, and pharmacies are either making a killing on it or they're losing out to the insurance company when selling these products. Okay, so there's an enormous amount of variation in the profitability of generic drugs. This is why you might have noticed that pharmacies love generic drugs. Okay, Walmart has made a business out of selling pretty much exclusively generic drugs because it's vastly more profitable if you're a pharmacy to sell a generic drug. Obviously, if you're a drug company, the reverse is true. You want to sell a brand, you want to discover a branded drug and sell it rather than selling a generic. Okay, so now I'm going to have to fly through some of the details here, but the issue is that we want to understand the effect of the size of an insurance company on the profits that are being earned by the pharmacy on each pill. Okay, so if I'm selling to Aetna, and Aetna has gotten really big, do I earn less profits per pill on the prescriptions that I'm selling to Aetna's patients? Okay, that's the key issue. So what I want to identify is the effect of Part D enrollment, which is a measure of how big the insurance company is getting, on the profits per pill for the pharmacy. Okay, I've already talked about this. So the issue here is that if you just run a simple analysis where you look at how enrollment affects prices and profits, you might be worried about it for a number of reasons. Okay, one reason is that, in fact, we don't know how big commercial enrollment is in these insurance companies. Those data are unavailable. So if you're worried that the size of an insurance company's Part D enrollee pool is correlated with the size of its commercial enrollee pool, you're going to get biased results because the effect that I'm estimating on the basis of Part D enrollment is kind of glomming on to some of the unobserved change in commercial enrollment as well. So that's one problem. Another problem you might be worried about is that insurance companies that anticipate better deals in the future might somehow be willing or might somehow be able to attract more enrollees by transmitting the information that they have about getting better deals. Okay, so what you need is some kind of natural experiment in which you can isolate the effect of enrollment on profits and prices. And what we use two things to that effect. One is that we use something we call potential Part D enrollment. Okay, so the idea here is if you're an insurance company, you probably have some geographic presence. Some insurance companies have big presence in the Sun Belt, some are in the Pacific Northwest, some are in the Southeast, some are in New England, etc. And it's not so easy to go into a new state. In fact, it's a real pain in the ass. The regulations, as you might have heard in the political debate, insurance regulations are state-specific, so there's quite a bit of cost associated with entering a new state. So if you're an insurance company that's present in a state with a ton of old people prior to the passage of Part D, you're in a really good position to suddenly end up with a lot of new Medicare enrollees compared to an insurance company that was present in a very young state before the law was passed. So essentially, your geographic presence or representation affects the degree to which Part D helps you. Okay, and arguably, your geographic representation is unrelated to all this other stuff about whether you're a better negotiator or whether you have more commercial enrollment or et cetera. Okay, so the issue is we use potential Part D enrollment as a way of measuring access to uninsured Medicare beneficiaries and using this kind of as an experiment for how big companies are getting. So to give you an illustration of this, here's a simple table showing 4 different insurance companies. You'll notice that they're ordered from small to large, where member health on the top row is the smallest and Long's PBM is the largest in the bottom row. But you can notice that potential Part D enrollment is not a simple function of the insurance company's size. In fact, the smallest company in this table actually ends up with the biggest potential Part D enrollment and the biggest actual Part D enrollment. Okay, so member health, because it's present in Florida and the Sun Belt more than the other companies, gets way more Medicare enrollees after Part D is implemented. So geographic presence seems to predict the extent to which you get bigger after Part D is implemented. Okay, the other experimental variation we use is something we call the pure price of coverage. So this is essentially how aggressively you're pricing your coverage. Okay, so if you think about there being a generosity of the insurance plan, there's some cost associated with offering generous insurance plans. But some companies are giving really good big discounts off their cost, and some companies are squeezing out very high premiums in order to make more money on each consumer. And how the pure price of coverage, or the extent of the discount you're giving to your insureds, is also going to predict how many enrollees choose your plan. Okay, so if you're the Walmart of insurance companies, you're going to get a lot of people going to you. If you're the Neiman Marcus of insurance companies, you're going to get fewer people going to you. Okay, now arguably you can say that Walmart sells lower quality goods than Neiman Marcus. So we do have to adjust for kind of the sense of how generous or how high quality is the coverage that each company is offering. But we can still see differences in price even when you condition on the generosity of the coverage. And in fact, there's one company in particular, Humana, that's just conducting a fire sale on Part D insurance. They're about 50% lower in their premiums charged compared to their nearest competitor. They get a ton of enrollees. Now, Humana had an announced policy at the time that they said, we're going to enroll all these people in Part D by offering them fire sale prices, and then we're going to covertly transition them into our Medicare HMO policies, which make us a ton of money. It didn't turn out to work that way. Nobody transitioned into their HMOs. Humana took a huge write-down. The CEO got thrown out. It was a disaster. But what was clear from a research perspective is that Humana was engaging in loss leader pricing for its Part D coverage compared to other firms. Okay, I won't go into there are some issues we have to deal with in thinking about Humana and the analysis. I'm going to kind of skip that over in the interest of time and just get to the results. So if you think about, I'm going to show you this table. I think it summarizes a lot of what we're doing here. So if you look at how profits per pill change with Part D enrollment, what you'll observe is that for generic drugs, right, an additional 1 million Part D beneficiaries leads to about a 25% decline in the prices that pharmacies sorry, a 25% decline in the prices that pharmacies are able to exact from an insurance company. So pharmacies are getting hammered by larger insurers. But the other point here is that there's no statistically significant change in pricing for branded drugs, okay, which is consistent with this notion that for a branded drug, the manufacturer is eating all the cake and leaving nothing but tiny crumbs for the other two kinds of firms to fight over. And if there's nothing to fight over, you wouldn't really expect there to be much of an impact of me being a bigger insurance company, because there's nowhere for me to go. There are no crumbs for me to latch onto, essentially. I can extract all I want from the pharmacy, but the pharmacy is just as poor as I am. Okay, so that's what goes on with branded drugs. With generic drugs, however, there's a huge effect of higher enrollment on pricing. You might also just look at prices rather than profits. You see largely similar patterns. There's a small effect on pricing for branded drugs. There's probably a small effect on branded pricing. In the other table, there were statistical power issues in detecting it, but it's about 10 times as small as the effect on generic drug prices. Okay, so then I'm just going to wrap up here with some implications. So if you summarize what we found, what you conclude is that for Part D enrollees, people switching into Part D, they generally experience about a 30% decline in prices paid for prescription drugs. This is partly because they're moving from cash payment, where they have no leverage at all, into being covered by an insurance company that can throw its weight around and bully the pharmacy. So a lot of that is just switching from uninsured to insured. But I think the really interesting thing is that people outside the program are also being affected. So if you look at commercial enrollees who are outside the Part D program and similar in age to Part D enrollees, and that's important because it means they're using drugs that are relatively similar to the drugs that are being used by Medicare beneficiaries, they're receiving about more than an 8% reduction in price for those drugs. And even for the young enrollees, they're receiving about a 3% reduction in price. If you add up all the price reductions for the people outside the Medicare program, they come out to about $2.5 billion, which is about 2/3 the size of the price reduction you see for the people inside the program. So these spillover effects are large and quantitatively significant. So essentially, we know that Part D has substantially increased the enrollment of these insurance companies. We've argued, Wes and I have argued, that this leads to greater bargaining power for insurance companies, and it lowers the profits that are made by pharmacies, particularly on generic drugs, okay, which is where there's cake to fight over for these firms. Nothing really happens to branded drugs because the branded guys are just basically laughing in the face of anybody who asks for a discount, and nothing happens to the insurance company's profitability or the pharmacy's profitability. The savings that accrue to the beneficiaries, it should be noted that that could be profits for the insurance company or it could be savings for insureds. That's actually not so clear. We don't look at that in this paper. There is a fair amount of literature showing that the insurance industry is not that competitive, but it's an open question as to how much of this money flowed into profitability versus savings and premium. If it went entirely to the insurance companies, just to give you a sense, it would have increased the profitability of these insurance companies by about 8%, which is a pretty big increase in profit margin for these companies. Okay, I went over. Okay, so sorry, let me turn it over to Mireille, and thanks for your attention.
Thanks very much. It's always good to be pushed to read your colleagues' papers, so I really enjoyed reading this, and I thought actually Darius was actually very modest about this paper in the sense that this is a huge, huge deal, this program. So Medicare Part D prescription drug coverage for seniors is the largest expansion of a public entitlement program since the introduction of Medicare in 1965. It was something that was fought over for quite a long time and had huge implications for the market for prescription drugs. So most of these facts are, if not all of them, are in his paper, but just to kind of restate them, approximately 12 million beneficiaries lacked prescription drug coverage prior to this expansion. And importantly for his paper, there are also another 10 million beneficiaries who are covered by Medicaid. So that's public insurance for the kind of poor and disabled. And so they also entered the private market. So their prescription drug coverage was negotiated through Medicaid, and actually we know that they paid very generously for prescription drugs for most of this period, and so were not in fact good bargainers. So then in 2006, millions of seniors obtained this publicly subsidized private prescription drug coverage and are kind of dumped onto this commercial market. They opted into this commercial market. So the question is, did this dramatic increase in the customer base of private insurers enable them to negotiate lower drug prices, kind of, overall? And they're going to test this by assessing whether those insurers that saw the largest increases in size also saw the largest decreases in prices. He makes a basic theoretical point, which actually he said was intuitive for economists, and I would beg to differ with that. So he says, so this was I love the line in the paper where it's like, the intuition is that it depends on the curvature of the supplier's surplus function. I'm not sure I agree with that being intuitive. And actually, I think I didn't get the economy of scales point. The way I was thinking about this, and I think this is separate from your point, is that what's really going to matter here is the relative market power of the buyer and the seller. And if you actually, and this is kind of the point for his branded drug, if you only have one seller and you're now increasing the size of the buyers, well, now I can just extract more rent, right? And that's kind of the finding, I think, for the stock prices of the manufacturers. A similar thing carries over for this paper broadly. And so, he's making the point, it's not actually empirically a priori clear what the finding is going to be. The other kind of really neat thing about this paper is he exploits, or they exploit, I guess Wes did the work on this, extremely unique data. He did the theory, the hard part. So pharmacy claims from a national retail chain, so think CVS, Walgreens, Rite Aid. Obviously they can't tell us what it is, but this is really unique data. And as Darius mentioned, the unique thing is that they're able to say something about the price absent the rebate, which is a big deal. And then they're going to estimate the relationship between changes in prices paid by insurers and Part D enrollment, comparing the last half of 2005 with the first half of 2006. So they're kind of trying to look at the sharp change between the period right before the program and the period right after the program is introduced. The empirical challenge, which Darius mentioned, is, what if well, this is one of the two that he mentioned. This is the one that seems most salient to me, which is, what if beneficiaries are able to select into those plans that negotiate better? Then you would expect to find that those with kind of the greatest increase in market power are able to negotiate better prices, but in fact, it's kind of a reverse causality here, right? You'd find this negative correlation, but it would have been that people opted into the plans that had more negotiating power, not that they caused them to have better negotiating power. And so what he does to handle this is something used fairly commonly in empirical economics, which is an instrumental variable strategy, or what I'll call an IV. And so the idea here is that you want to look for something that's correlated with the independent variable, the thing you're interested in, which here is the change in kind of the insurer size. And you only want it to affect your outcome. Here it's our change in prices through this effect on the independent variable. And so this is actually much more challenging than it sounds. So just to give you some examples to try to make this intuitive, some of the classic kind of IVs in the literature look at things like the relationship between military service and earnings. So what's the difficulty there? Right? It might be that you're more likely to join the military if you don't have good earnings potential, right? You don't have a good labor market that you're looking at, so you say, okay, maybe I'll join the military, and then your relationship between kind of military service and earnings is not actually showing you a causal effect. And so what Josh Ingris did in 1990 was he used Vietnam draft, and he looked at your draft lottery and tried to use that to predict your service and then your future earnings. In health, a kind of classic example is trying to look at the effect between intensive medical treatment and health outcomes. So the question here is, like, if we do more stuff to you in the hospital, is that good for outcomes? There's a big debate about this, actually. This kind of classic paper, I think in JAMA, or New England JAMA, is that right, 1994, looks at differential distance to kind of specialty hospitals, and tries to say, predicts your likelihood of having gone to this specialty hospital where they do more stuff to you for cardiac care based on your distance, how that affects outcomes. And they find, in fact, that if you happen to be closer in a differential sense, so from your basic hospital to this high-tech hospital, that you A, got more stuff, and B, you did better in terms of mortality. So these are hard things to find, and you can almost always think of a case for why that thing that you think is independent and only affects your kind of only affects your outcome through your key independent variable also has some kind of other relationship with the outcome. And so Darius and Wes use potential enrollment, so the sum of seniors without private health insurance in 2005 across states where the insurer operates to predict the actual change in enrollment. The problem they mention is, I think, a key one, which is that your potential enrollment may also measure your ex-ante market power in the sense that if you're an insurer that's quite dominant, you might be in lots of states, and then you're going to have greater potential enrollment. So I just wanted to think of some alternatives, and so one idea I had was actually to exploit the random assignment of low-income beneficiaries. So this is kind of a detail of the program, which is that those beneficiaries that I said were on Medicaid as well as Medicare, the poor ones, poor or disabled, they were actually randomly assigned to plans that were quote unquote below a benchmark. So what happened was, actually I'm sure he can describe the process better, but essentially in 2006, it probably was in 2005, the plans came out with their premiums, and then within a market, they took the average premium and said those below the average are below the benchmark. They're kind of the cheap plans, and these kind of poor or disabled beneficiaries were automatically enrolled into these plans and actually randomly assigned to them. And so some plans saw huge increases, those plans below the benchmark saw huge increases in their enrollment. And here's actually something I've been kind of working on, which is trying to look at what the effect is of getting all of these beneficiaries kind of randomly assigned to you on a set of outcomes. So here, the benchmark actually varies by market. So you take the average in a market where there are something like 40 some odd markets across the country. And you can see that those plans that are above the benchmark have much lower enrollment than the ones just right below the benchmark, okay? So it's something like 15,000 to 20,000 more enrollees in your plan if you happen to be just $1 below the benchmark, okay? So this operationally is a little bit challenging for them because, of course, these are plans, not insurers. So you can be an insurer who has a plan here and a plan here, and so there's needs to be some thought put into kind of how you characterize insurers relative to the benchmark nationally. But I thought that would be kind of a neat way to look at a change in enrollment. So did you get just this large shock in enrollment just because you fell right below the benchmark and were randomly assigned a ton of people? Then there's some kind of, just to show you what it's really like to give a discussion at an economics seminar, I thought I'd just point out some nitty-gritty things. I'm sure they've heard in referee reports or whatever, but I would have liked to have seen the results without some of the controls that seem potentially endogenous. So changes in pills per prescriptions, market power of the pharmacy, and then the falsification test. So they do this falsification test in the paper where the paper is focused on the last quarter of 2005 and the first quarter of 2006. They do a falsification test, let me see if I get this right, which is the last quarter of 2005 and the last quarter of 2004. Is that right? Something like that? And so basically what I thought they should do is do the exact same test but shift it back 1 year. And the reason you do that is to deal with potential seasonality. I mean, I don't know this market well enough to say whether there's seasonality, but there are lots of products that their prices depend on the time of the year. So you could imagine, here's why you might have a case like this. So suppose in cold weather that causes all sorts of falls, and people have much greater demand for pain relieving medicine during the winter. That would lead to seasonality in prices and is why you might want to use the exact same kind of time period in a different year or a different, shift back just a full year to get the same quarters of the year in your test. Another kind of suggestion, which is not a, you have to do this or I don't believe your results, not that those were, but let's tighten it up kind of comment, which is what we're really good at in economics, is just something more to push a little bit more on the therapeutic class. I thought would be really interesting. In particular, I was curious, is the impact of bargaining power largest for Medicare beneficiaries? Largest for classes where Medicare beneficiaries make up a large share, or do you see similar effects for classes where there are no beneficiaries? So like think about, or very few, think about infertility drugs or birth control. That's not a big class for the over 65. And so it would be really interesting to know, does this bargaining power kind of spill over in that sense? So it's a different notion of spillover. And just to make this intuitive to you, a totally different example, the idea here is, Ford increases their market share. And, it clearly has more market power as a purchaser of auto parts, but does this carry over to completely kind of unrelated things, so janitors? It's actually not a priori obvious. And just another way to state this is, does your market power matter by drug or by dollars? And so overall, I thought this was just a really nice, cool paper, both theory, empirics, data, that I was happy to both read and comment on. So thank you very much for the opportunity.